Welcome to the Egg Whisperer Show, a podcast exclusively designed to create more reproductive health awareness and discuss your fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Aimee.
Hi, everyone. Thanks for joining me on tonight's show. I'm Dr. Aimee, a fertility expert here in the San Francisco Bay Area. I get questions from all over the country and world about IVF every single day, so I just thought it made sense to do a show on the most commonly asked IVF questions. And so I put a call out last week to everybody on social media, and I basically said, send me your questions. And I have received so many questions from around the world. So I thought, I'm going to read the questions tonight, but not only that, I just thought this would be a good opportunity to send another call out and say, if you're watching this show, and if there's a question that I haven't answered that you have, do send it in. Email at eggwhisper.com, because it seems like this type of question and answer format might work really well for people because you might have the same questions. Watch the show, and hopefully if you haven't had your question answered by watching this show, you certainly know where to start and you can go talk to your doctor. During my shows, I often put up a slide that says, ask more questions. So here we are with lists and lists of awesome questions. And I guess the first one to start off with is, what is IVF? So let's just talk about what IVF stands for. IVF stands for is very fun. No, it doesn't stand for that. It actually stands for in vitro fertilization. And it's basically the process of taking an egg, I'm dropping my egg, and sperm, and putting them together and making an embryo inside an IVF lab. Clearly, basketball, it was not my sport. And then this is basically what an embryo looks like. So this is a beautiful watercolor painting a patient had made for me as a gift. And her babies are now, she actually had twin boys, are now 1 year old. So happy birthday, guys. So during the process of IVF, if you haven't thought through what's involved, what side effects to look out for, do make sure that you know these things before you start. And the reason why I try and be as thorough as possible is because I don't want anyone to feel like something's going wrong when it's an expected side effect. I'll give you an example. I've gotten calls, for example, at 10 o'clock at night. Oh my gosh, Dr. Aimee, I'm experiencing this egg white cervical mucus and I think I'm ovulating. Well, since I had gotten that call once, I actually now try and explain to patients that as your estrogen levels go up, your body responds to that hormonal shift and you react in a similar way as in a natural cycle. And so what that means is you will notice egg white cervical mucus as your estrogen levels go up. But it doesn't mean you're ovulating like in a natural cycle. And the reason is we give women medications to prevent ovulation from happening. Let's get to more questions. How soon can we begin treatment? Well, that's a really good one. And what I tell patients is your timeline is mine. So there are certainly things that I do. Voila, Tushy method. Hello. I like to diagnose people's fertility issues before treatment and gear their protocol toward what I know is going on. And I like to give people an opportunity to make things as awesome as possible before we start treatment. I'll give you an example. Let's say sperm counts are low. Well, I'm going to have you consider a healthier lifestyle, taking supplements, seeing a urologist if necessary, doing extra DNA tests, for example, a DNA fragmentation test. So we know if, for example, a procedure like PIXI is necessary for you. So those are things that we do ahead of time. So I can have someone come into my office day one today, period started, see me as a new patient. I can start IVF tomorrow. The reason is I run IVF 7 days a week. I'm like 7-Eleven, but you can actually call me and get medical advice, but you can't do that at the counter at 7-Eleven. I'm sure you could try. You can walk in and ask a fertility question, but you may not get the answer that you want. So I actually make that joke. And then someone actually told me, Aimee, 7-Eleven is open 24 hours because I said I'm like 7-Eleven, but open 24 hours. And I learned the hard way that it's actually open 24 hours. What is your success rate for IVF? And that's a great one. And there's an online calculator tool that I pull up for patients and I put in their age, I put in their height, weight, how many times they've been pregnant, what their fertility diagnosis is, and I actually give them a percentage. And this information helps them go with the right set of expectations. So you want to ask yourself, how many cycles is it going to take to get the family size that I want at the age that I'm starting? And what's my fertility diagnosis? So just being aware of all these things can only help. Will I need to be on birth control pills before IVF? So birth control pills sounds kind of like counterintuitive, right? You want to get pregnant, but someone's saying you need to start birth control pills. There actually are some situations where taking birth control pills will help women with lots of eggs. Let's say an egg donor. Another scenario would be you need to have your IVF egg retrieval fall on a very specific day because of your travel plans, out of town plans, your partner's plan. So we use we use birth control pills as IVF readiness pills. And I wish the pack would actually say for IVF patients, IVF preparedness pills, because I can tell you, having someone tell me that I want to get pregnant, but I'm going to take birth control pill, that would make me confused too, especially if you have bad side effects to birth control pills. So some centers don't run IVF 7 days a week, so they have to put their patients on birth control pills. That makes sense for them. That's what they have to do. So find out, along the same lines of what's my fertility diagnosis and what's the best protocol for me, because for some patients, taking birth control pills may not be the best option because it may lead to less egg production. Typically, in my patient population here in the Bay Area, most patients are over a certain age, so I like to approach cycles using a natural cycle approach. So day 1, period starts. Day 2, you start meds. So that is what I think can help women with a lower number of eggs. Next question. Do you foresee any problems that could arise? And the answer is there are things that you can learn throughout the cycle. Step 1, you show up for your baseline ultrasound. So that's the ultrasound that you do before the cycle starts, and you find out there's a cyst or your estrogen is high. So it's like, wait, we're not going to take off from that landing pad. And that's okay. These things happen. Women who ovulate, it depends, a certain percentage of the time, I think it's about 25% or less, may show up and have a cyst on their ovary, so you can't start the cycle. Or if your estrogen's high, it may be a sign that you may not get as many eggs in that cycle. The next thing that you might learn is that this protocol might not be for you. So I take these things as learning experiences, and I tell my patients who go through something like this, I say, look, there are signs that this cycle may not be the best one for you. So let's hold off, save your meds, take a little break, maybe try naturally. Next cycle, let's try again and see what we learn from this cycle, maybe approach things a different way. Another thing that you can learn is that at the time of the egg retrieval, you may have not retrieved as many mature eggs as you would have liked. Another thing that you might learn is that the fertilization rate might not be as high. Another thing that you can learn is that the embryo progression rate isn't what you expected, or that the number of blastocysts was either not what you expected or you didn't get blastocysts at all. And the last thing that you might learn is that you don't have any genetically normal embryos. So again, talking through these scenarios is so important. But what I tell my patients is sometimes the cycles that look the worst sometimes are the best, because it literally just takes one egg, one embryo to have a successful pregnancy. Obviously, there's a lot more that goes into that. It has to be healthy, strong. You have to have a successful implantation. But it's important to have a care provider that's going to listen to you, understand your cycle, and communicate well with you about what's going on. Because if it doesn't work, it's frustrating for people that see me and they say, I wish I would have asked more questions going into this cycle. Because if I had known these things ahead of time, it would have not been as frustrating. When my patients go to sleep for their egg retrieval, sometimes I ask them, I say, hey, look, can you tell me, how did the cycle feel for you? Was there anything that could have gone better? What are the biggest complaints that you have? And oftentimes the biggest complaints my patients have are, I feel like a potato, or I didn't expect to be as gassy as I really am. Those things make me chuckle, and that's actually good news to me. Do you prefer day 3 or day 5 transfers? So most of my patients actually do genetic testing. That's the process of going through IVF with PGS, which is now called PGTA, which is pre-implantation genetic testing with aneuploidy, and a frozen embryo transfer. This involves step 1, getting embryos, getting them frozen, making sure they're normal. Step 2, planning for transfer, potentially doing implantation testing. Step 3, going ahead and doing the frozen embryo transfer. I do have patients that choose for whatever reason to do a day 3 transfer or a day 5 transfer, but I talk to my patients about the importance of genetic testing and how it can increase your chance for pregnancy and decrease your risk for miscarriage. But it is not for everybody. You don't have to do it. It is still considered a somewhat murky crystal ball, and it does not tell you everything. You cannot make a super baby doing IVF, and it is still safe to get pregnant at home if you can. Next question is, do you do a mock transfer? So for people who don't know what a mock transfer is, there are a couple of things that it refers to. A mock transfer is kind of like a practice run. For example, you have a catheter and you place it into the cervix and enter the uterus with it, and it just allows you to make sure that you can get in without a problem. The last thing I would want to do is have a catheter that has an embryo in it and can't get it into someone's uterus on the day of the transfer. I want to troubleshoot those things in advance. So if there have been problems, let's say, for example, you've gone through intrauterine inseminations and done IUIs and your doctor could not get into your uterus with that catheter, make sure you've done a cervical dilation ahead of time, that you've done a mock transfer. All those things can just help improve your success rates. The other thing that I do is called a mock cycle. Because embryos are so important to me and I need to go to sleep at night knowing that I've done the very best for each and every single one of my patients, I like to have patients consider implantation testing. The last thing I would want to happen is to transfer an embryo and then have a negative pregnancy test and then tell a patient, there was a test that we could have done and it might have improved your pregnancy rates. That's not a conversation I would want someone to have with me after a negative pregnancy test. So I choose to treat patients the way that I would want to be treated myself if I were the patient in that situation. So knowing what these tests are ahead of time gives you the opportunity to research them, talk to your doctor, and see if they're for you. So that process involves taking medications just as if you're going to do a frozen embryo transfer, but instead of doing a frozen transfer, you come to my office, I take a catheter, put it into the uterus, but instead of pushing an embryo in, I'm going to withdraw on the catheter, bringing up cells into the catheter. I'm actually going to withdraw on the syringe, bringing cells into the catheter and sending them off to 2 labs. One lab tells me about inflammation, endometriosis, and BCL6 histologic score, and the other lab will tell me the number of hours of progesterone that your body needs in order for implantation to occur. Next question. Do you test the uterine wall to make sure it's receptive? And the answer is yes. That's all part of doing the scratch. That's another question. Do you scratch the uterine wall to help with implantation? So all those things can be done at once. You can do a saline sonogram when you do the endometrial testing. You can do an endometrial biopsy, which is basically a uterine scratch, all at the same time. So the next question is about intralipid therapy. So intralipids is basically like getting a smoothie from Jamba Juice, but having it go into your veins. Does it help? I don't know that we really know that. There's a lot of controversy out there in the literature. In fact, there was a recent meta-analysis, actually a Cochrane review, reviewing all the literature on autoimmune treatment of fertility patients, including intralipid therapy. And it seemed like it may not help. But I think in certain cases, you sometimes have to think outside the box, and adding intralipid infusion isn't harmful at all. I mean, going to Jamba Juice doesn't hurt you. Sitting for 2 hours and getting someone egg yolk protein through a vein, it wouldn't hurt unless you had an allergy to that. But I don't necessarily prescribe it up front, and it's not something that I do as a standard treatment. What sort of medication for IVF would you prescribe? The decision-making for me, as far as which medications to prescribe, is based on your age, your AMH level, how many follicles you have, and what the patient wants. So one of the myths is that you have to take lots and lots of drugs, shots in your butt, and you have to do those things to get lots of eggs. And the answer to that question is it's really individualized. Every patient's different, and I have some patients who actually want me to get less eggs, and that's okay. And I have some patients that are very okay with me extracting more eggs. So the one thing to talk to your doctor about, though, is what are you going to do with those eggs when you get them? So if you're 29 years old and you have 20 follicles, do you really want to make 20 embryos? If you're 39 years old and you're lucky enough to have 20 follicles, well, you may actually want to make embryos out of all of them, because we know that probably 2 out of the 20 eggs will be genetically normal, maybe 3. So those are things that you want to talk about in advance. Next question is, which pharmacies specifically do you work with? There are a number of wonderful fertility pharmacies in this country that provide excellent customer service to my patients. So talk to your doctor. They're going to know who is reliable in your area, out of town even. We have some pharmacies on the East Coast, some pharmacies in Southern California, some pharmacies here in the San Francisco Bay Area. So also look at your insurance policy and see where you might have coverage and where you might have better rates. Next question is, which protocols do you prefer? So I prefer, in patients who are potentially over-responders, a protocol that includes an antagonist. So an antagonist is a hormone that prevents you from ovulating. But because you're on an antagonist, like the brand name ganirelix or cetrotide, you can then use a Lupron trigger shot and potentially with a low-dose HCG trigger shot. So that's kind of what I prefer for my over-responders. For my, let's say, patients who have a lower egg count, I prefer protocols that are similar to mini IVF protocols. I call those hybrid protocols, where you combine fertility pills with fertility shots. and other things to improve egg quality like supplements and HGH hormone. Another great question I get all the time is, do I need to lose weight before my transfer? And so what I do is also I calculate a patient's BMI. I look at the height, weight, and I calculate it. And then I say, look, this is the BMI that I think will give us the highest rate of success. Sometimes I ask patients to gain weight. Sometimes I do ask patients and I say, look, your BMI is, for example, 35. I think that if you lose 20 pounds, especially where you're carrying your weight, it may improve your responsiveness to the medication, and you may not require as much medication to get your eggs to grow. And you might save money on the medications by trying to lose weight. But it's kind of cruel and mean. You're going through something that's super emotional. You're feeling hungry because people are pumping you with drugs that mimic pregnancy. That's really mean to then say, and lose weight. So I like to celebrate all my patients' body size. I don't ever shame anyone for the size that they are. But certainly I always recommend eating really healthy, fresh fruits and vegetables, following a Mediterranean diet. And at the end of the day, your fertility is not skin deep. There are women who are curvy who can certainly achieve very healthy pregnancies. Do you allow more than one embryo to be transferred at a time? As you know from my personality, I try and make jokes. I say things like twins are really cute on Instagram. Twins are really great screaming in other people's cars at the same time. But in all seriousness, I've had so many awesome twin stories. Lots of patients who've had many healthy twin pregnancies. But at the same time, I haven't. To be honest, I've had patients who've lost their twins before 25 weeks, or patients who've had twins and due to prematurity have kids now with some disabilities. That's the honest truth. Any fertility doctor will tell you that. So I always encourage transferring one embryo at a time. And if a patient does want twins, I try and educate them about the risk. And almost always, my patients in 2018 agree that transferring one does make the most sense. Do you recommend acupuncture during the cycle? I actually did a fertility acupuncture show. If you haven't watched it, you should. So I think acupuncture is great for a number of reasons. It's great to help you through the symptoms of going through an IVF cycle. I told you, you can feel potentially super bloated. You may even feel emotional, maybe a little stressed, feeling fatigued, or what I call you might start experiencing the estrogen fog. And I think especially with symptoms like nausea and the bloating, acupuncture might help you. Acupuncture can also help my patients. What I've found is with the symptoms post-retrieval of recovering. So my patients who go through acupuncture, I feel like recover the easiest and best. And also acupuncture in pregnancy can help with the joint pain, the nausea. There's so many benefits. How long will the IVF cycle take from day one to transfer? I totally get it. You've been trying, let's say 1 year, 2 years, 3 years. You've decided to do IVF and you want to be pregnant yesterday. But I try and take my time with my patients and do my very best so that they feel like they're doing things at a time frame where they're getting the results that they want without rushing a single thing. But typically it can take anywhere from 1 to 3 months to achieve the cycle results that you really want. So going on to other questions is, does age matter and how soon you can repeat IVF after delivering your first child or previous child? And the answer is, I encourage patients to wait 18 months between pregnancies. We call that the interpregnancy interval. So the interpregnancy interval of 18 months or greater has been shown to provide babies and moms with the best outcomes, meaning lower risk of preterm labor, lower risk of preterm delivery, lower risk of preeclampsia, bigger babies, healthier babies, and lower rates of autism. So I strongly encourage patients, especially who've had a C-section, to wait at least 18 months, and women who've had a vaginal delivery at least 12 months. And certainly that 18-month rule is something that I try and encourage patients to go by. How soon after delivering should you look into doing another round of IVF? So that's for patients who don't have any embryos left over. So if you don't have any embryos left over, then I tell patients, look, get your AMH checked, see what's going on, and maybe 3 months after delivery, consider doing another cycle. That's a really good question because sometimes patients wait too late. They want to enjoy their baby. They want to enjoy the, infancy. And then they wait 2 or 3 years to start asking that question. And at that point, we all know what happens with our biological clock. So I strongly encourage patients at your postpartum visit to get your AMH level checked and then talk to a fertility specialist if there's some action that you need to take so that you can preserve your healthy, younger eggs. What would you suggest I take supplement-wise during this wait for transfer and after, as well as into the pregnancy? So this is another question that I got about a patient who was transferring this week, and she wanted to know what kind of supplements she should take. And I certainly get this question all the time. I highly recommend a really good prenatal vitamin with fish oil and making sure that your vitamin D levels are normal. During the pregnancy, you can also, and before, take a probiotic. And then as far as supplements, and you've probably heard of things like bromelain, that's in the core of pineapples. That's not based on any valid scientific evidence as far as improving pregnancy outcomes, but certainly you've probably seen it as being the symbol of infertility. And I love that the pineapple is, but cores are awesome, soaked in rum with lots of whipped cream. That's about the only way that I'll eat a core if it's stuck in a yummy drink. Otherwise, no core for me, because that's just too fibrous. So another question is, some insight on empty follicle syndrome may be helpful. What is it? An empty follicle syndrome, as far as I'm concerned, is probably a failed trigger shot. It is a very, very rare syndrome. And so if a woman gets a trigger shot and then has an egg retrieval and no eggs are retrieved, it's usually she ovulated, there was a failed trigger shot, or the eggs were super, super immature. So talking to your doctor about those possible scenarios is really important. If they're saying you have empty follicles, the reason for the empty follicles could be potentially one of those three things. What are your thoughts on genetic testing of embryos? I'm not convinced the chances or results are any different than naturally conceived pregnancies. Great question. And the answer is, as far as whether you should do genetic testing or not, it's such a personal thing. And the reason is this: it's based on your age, your diagnosis. So for example, if you've had multiple miscarriages and you know that they were genetically abnormal, genetic testing sounds like the right thing to do. However, if you're 29 years old and your egg quality looks good, you may not want to do or need to do genetic testing, but you wouldn't know. The good news is this: you can always test embryos in my hands, meaning in my practice. If you've had them frozen, you can always thaw, biopsy, refreeze them, get the results back. So if I have a patient, let's say, for example, who has like 10 to 15 embryos, she's so lucky to have that, she can then consider genetic testing them in the future. So if you transfer one embryo, and I've talked to patients about that, have a successful pregnancy and a live birth, we can still test at a future date. Not all labs have the ability to do that, so be sure to talk to your doctor ahead of time if that's an option for you. And you can also consider moving your embryos, which is not something that I strongly have patients, I encourage. But if you want to get that information, if let's say something has changed and you need genetic testing on your embryos, that's still an option for patients. So another question is about thyroid disorders in women who are going through IVF and whether I treat them or not. And the answer is yes. Checking someone's TSH is part of our routine fertility care. And you can see it. It's in the H in my tushy. Where's my H? Right there. So we look at hormones, and thyroid is one of them. And we like to maintain a patient's TSH level at 2.5 or below. I have so many questions, you guys. I have pages and pages and pages. You guys, this is way too fun for me. Thank you, everybody, for sending these questions. And I think that by getting questions like this, it just makes me think this type of show is something that we should do more of. So another question I got was, I'm starting IVF due to severe male factor infertility this week. What questions should I be asking at this appointment since this is new territory for us? Oh, love this question. Question number 1, what can I do to make the sperm even better? Yeah, you can make those swimmers potentially even better or faster. There are a number of things that you can do, but you have to know, why is the sperm that way to start with? So is it lifestyle? Is it heat exposure? Don't cook your balls. Is it drinking too much, smoking too much, diabetes, hypertension, high cholesterol? What is causing the sperm abnormalities? Is it a varicocele? So make sure you've seen a male fertility specialist, a urologist, someone who can diagnose the anatomic issues, someone who run the hormone test and has done the genetic testing, like a chromosome analysis and a Y chromosome microdeletion. And then ask the questions, are there drugs like Clomid, HCG injections, HGH that can potentially improve the sperm count? Should we consider supplements? Is the DNA fragmentation very high? For example, if it's over 35, potentially consider a sperm harvest, like a Tessie procedure. So those are things that you want to ask in advance of your cycle. So going through those questions that I just reviewed with you will certainly help in a situation of severe male factor infertility. So, and thank you for saying, I love your show and really appreciate the tips and openness about infertility treatments. Thank you so much. So thank you for that. I appreciate it. Okay. So this is another patient, 31 years old. Husband is 33. She's had regular cycles, and husband has no sperm because of a condition that I see enough called congenital bilateral absence of the vas deferens. So what that means is that her husband cannot ejaculate sperm, but there is sperm inside the testicle. So in this scenario, what she has asked, she's actually shared a certain situation that happened to her, is that in the emergency room, she had to go to the emergency room because of high estrogen levels. And it turned out this is a good story. So not good because it happened to her, but good for me to share. So she took estrogen, and the estrogen hormone caused her to feel really, really anxious. And then she had to go to the emergency room because of her anxiety, and they wanted to rule out a stroke. And in the emergency room, she had a CT scan, and she developed an allergy, or didn't know she had the allergy, to the iodine contrast used. The CT scan was thankfully normal, and her anxiety required her to see a psychiatrist who advised her to give her body time to heal and wait a month for transfer. So her question is this: do you recommend waiting a month for the body to recover? And the answer is yes. But listen to your body, right? Your body is saying, get that estrogen poison away from me. So there are some patients that feel really good on estrogen. And I would say I have maybe 1 out of 50 patients that just cannot tolerate it. And if you're one of them, don't force yourself to take it. Because the last thing we want is to put patients into like some sort of psychiatric clinic, or not clinic, or hospital because of the hormones that we're giving them. Going through this process is emotional enough. So taking medications that make you feel like you're going to lose your mind, talk to your doctor. There are other options. There are estrogen patches rather than the pills. That sometimes is something that you can do. There are cycles called natural cycle transfers. You can do that, meaning no hormones at all. Just follow your natural ovulation, transfer 7 days later. Think of ovulation day as egg retrieval day, and then count out the number of days where you would have a blastocyst, and that's when you would transfer your embryo. Okay, next question. This is also along the line of mood disorders. My depression is bad, but not suicidal or a threat to anyone. My boss is aware that I have medical issues. When I get depressed, I see a significant cognitive decline. Starting my first IVF cycle this week, I have ways of coping. Have you ever had a patient with a psychiatric disorder, and how do you handle this? And the answer is yes. And again, it's part of the process of going through hormones and seeing negative results. It can really weigh heavy on you. Heck, it weighs heavy on me. I have all sorts of tricks that I use to make sure that I get up in the morning and I'm as peppy as I am at work, as you see that I'm here. I mean, I don't wear a t-shirt like this, but I certainly have ways to improve my mood. So making sure that you have your fertility team, a therapist, someone that's going to help you with a nice exercise routine, an acupuncturist that's on your team, meditation, mindfulness, all those things are so important as you're going through this process. And just because you're on psychiatric medications or being on psychiatric medications does not prohibit you from going through IVF and being a mom. Being a parent is transformative, and it can definitely, potentially help you find your role in this world and can potentially, I feel, lessen your symptoms of depression. Okay, this is super, super cute. This is from a woman's partner, and he asked these questions. Is there anything I can do to take the burden off of her? Isn't that sweet? Right? So what I tell the partners of my patient is just always ask your partner, what can I do to help? How can I help you? What's going on? What are you, it's just, what can I do for you? How can I help you? What do you need today? What do you need in this moment? Those kinds of questions, and repeating them. And then if she looks at you and be like, I'm fine, then just ask, well, I'm here for you. Or just say that, because I think having a supportive partner and being a fertility team together, I mean, I talk about the team and all the elements of it, but having a fertility friend, a partner, and making sure that you're well aligned and talking to a therapist together, I think is super important. And this is another question. Do you recommend seeing a therapist during IVF? And the answer is yes. And this is another question. Is there anything I can do from a dietary perspective to improve my sperm morphology? And we kind of talked about that already. And will you try to diagnose the core issues of why we've been unsuccessful and treat those prior to starting IVF? And the answer is yes. And that's why I'm wearing the tushy shirt, because that's what I'm all about, is fertility diagnosis before treatment and personalized fertility care. So I've answered so many questions tonight. Thank you to everybody for sending them in. Thank you guys for watching tonight. I hope that you learned a ton. And I hope that I opened your eyes to potentially things that you didn't even think about for the fertility care that you're going through. Have a great night.
Thank you so much for listening and making the Egg Whisperer Show a part of your weekly routine. To find show notes and a full transcript for this episode, visit draimee.org and look under the blog tab. While you're there, you can find a link for the Egg Whisperer newsletter, which keeps you in the know about fertility news. You can also find Dr. Aimee and the Egg Whisperer Show on YouTube, Instagram, or Facebook. If you'd like to learn even more, Dr. Aimee offers classes at the Egg Whisperer School, eggwhispererschool.com, or you can request a consultation on draimee.org. Thank you so much for tuning in and for sharing the Egg Whisperer Show with others. Keep sparkling and have a great day.